Thank you very much, Kathy, and good morning to all of you. It's good to see you here at this hour and participating in our symposium. As Kathy said, I'm going to be talking about fortification and health of the nation, what it can and can't do. First, this is my list of conflicts of interest, is that right? Conflicts of interest? I'm on the Scientific Advisory Board for ConAgra. I receive funding from various organizations, and I've also provided consultation to the Alliance for Potato and Research and Education, and also to ILSI. I want to cover these 4 topics in my talk. What is fortification? What can fortification do? What are the limits and challenges of fortification today? I think they differ from what they were about 100 years ago. And what issues need to be addressed going forward? So first, let's start with what is fortification? It's the addition of nutrients to food or food constituents such as flour, or to food supplements or supplemental products. And there are basically 2 different types of fortification. One is the enrichment or mandatory fortification, and the other is discretionary fortification. The mandatory fortification is those nutrients that must be added according to a standard of identity established originally by the FDA in the 1940s. And it defines specifically what nutrients can be added and what amounts they should be added. So the mandatory fortification refers to the fortification that we do for thiamine, niacin, riboflavin, folic acid, and iron when it is added to enriched flour. And the purpose for doing that is to replace the nutrients that are lost in processing or refining the flour. Discretionary fortification is the addition of vitamins and minerals to food at the discretion of food manufacturers. In other words, there are no standards around the discretionary fortification, and there does not need to be a demonstrable public health concern in order to add those nutrients. So adding calcium to orange juice, for example, is an example of discretionary fortification. But we may also add additional nutrients to the foods for which there is an enrichment standard. So we have an enrichment standard for flour. We could add other nutrients besides the B vitamins and iron to enriched flour, and that would be discretionary fortification. There are 6 principles that underlie the FDA's fortification policy. First, the nutrient intake without fortification is below the desirable level for a significant number of people in the population. This must be demonstrated. It also must be demonstrated that the food fortified is consumed in quantities that will make a significant contribution to the population intake. It must be a food that is common across the diets of all of the diverse groups that we have. And that the addition of that nutrient is unlikely to create an imbalance among the essential nutrients, such as possibly an imbalance between folic acid and vitamin B12. The nutrient needs to be stable under proper conditions of storage and use, and it should be physiologically available from the food to which it is added. Also, there needs to be reasonable assurance that it will not cause toxic intakes. So you're going to hear in the talks that follow me this morning some discussion of these principles and our ability to adhere to them or not to adhere to them as we go forward. So when and why was food fortification first initiated in the United States? The first example of fortification in the U.S. occurred in 1924 when iodine was voluntarily added to salt to address an endemic goiter. And our iodization of salt today in the United States still is a voluntary action. It is not mandated by the FDA. Even though there are about 120 countries worldwide where iodization of salt is mandated, that is not the case in the United States. And as you know, when you go to the stores, you can buy iodized salt or non-iodized salt. You have a choice. In 1933, vitamin D was voluntarily added to milk to prevent rickets, and that still is a voluntary action in the U.S. today. In 1940, the Committee on Food and Nutrition, which is now called the Food and Nutrition Board of the IOM, recommended the addition of thiamine, niacin, riboflavin, and iron to flour. And initially, the addition of these nutrients to bread was voluntary. But in 1942, the Enrichment Act was passed, and now it's required that all grain products crossing state lines must be enriched with these nutrients. Then in 1945, there was the addition of fluoride to public water, again a voluntary action. More recent mandated fortifications have occurred since the early 1940s. In 1952, it was mandated that oleomargarine be fortified with vitamin A. Butter does not need to be, other fat sources do not need to be, it's just oleomargarine. And in 1996, folic acid was added to the list of nutrients that must be in all grain products, and that was a modification of the 1942 Enrichment Act. I want to review the history around the addition of iodine to salt in the U.S., since it was the first example of fortification that was done in the U.S., and to make the process a little bit more familiar to you. You see that in the 1917s, 18s, there was a goiter belt across the northwestern part of the United States and also into the upper part of the Midwest. And the incidence of goiter was very high in these countries, going up to as much as 60% or 75% in some cases among the children. It had been known for some time, as far back as about 1815, that iodine decreased the incidence of goiter, and this work was done initially by a scientist in Switzerland. However, that information was basically ignored until the early 1900s, when Dr. David Marin from Cleveland, Ohio, proposed a large-scale trial of iodized salt in the Cleveland public schools, but the school board vetoed his request to do this study, so he was not able to carry it out. Another decade passed before Dr. Marin, along with Dr. O.P. Kimball, tested the iodine administration in over 2,100 Akron, Ohio schoolgirls. They finally got permission to do the study. Showed a lot of patience on their part. And the goiter in the treated girls dropped to 0.2%, while as that in the controls was greater than 25%. So the outcome of this study was very clear that iodine can reduce the incidence of goiter in children. This led to a campaign to iodize salt, and Dr. Marin's work, along with Dr. David Cowie in Michigan, worked with the Michigan State Medical Society to eliminate goiter in Michigan by iodizing salt. It was approved by the Michigan State Medical Society, and iodized salt began appearing on the grocery shelves around the 1st of May in 1924, all done voluntarily by the salt producers. And in the fall of that year, you see this all moved very rapidly, the Morton Salt Company began selling iodized salt nationally. In 1942, the National Study Committee of Endemic Goiter determined that how much iodine should be placed in salt in order to prevent goiter in humans, and they use the same standard for domestic animals. Again, today the FDA does not mandate salt fortification with iodine. It is voluntary in the United States. The result of iodizing the salt at that time, back in the 1920s, led to a sharp drop in the incidence of goiter. These are data from Detroit, and you see that when it was began in about 1924, the incidence was around 35%, and by later on in 1935, it had dropped down to around 1 to 2%. So a very effective example of what fortification can do with respect to a health problem. Now, I want to compare the rationale and for doing fortification with respect to the early vitamins and a mineral that were fortified to the rationale for now adding folic acid. You see that when we were concerned about iodine, vitamin D, and the B vitamins, there was a clear public health concern that led to the fortification of those nutrients. For folic acid, there also is a public health concern, neurotube defects. But the link between neurotube defects and folic acid intake is not as strong as the link between pellagra and niacin, or rickets and vitamin D, goiter and iodine. So there were clear biomarkers of impact for the fortification with iodine, vitamin D, and the B vitamins. The biomarker for the folic acid is the prevalence now of neurotube defects. The etiology was very clear for iodine, vitamin D, and the B vitamins, low iodine in the soil, low vitamin D from sunlight and foods, and also high intake of cornmeal without animal source foods among poor southern families seemed to be the factor leading to pellagra, since that cornmeal alone, if it's not treated with alkaline, the niacin is not available. For the neurotube defects in folic acid, it was the evidence that there was low folic acid intakes among pregnant women. And the target populations differed. Iodine was everyone, vitamin D focused primarily on children, the B vitamins focused on the poor southern families at that time. Folic acid, the target population is pregnant women. We've seen marked reductions in the incidence of these diseases in the United States. Neurotube defects still exist in the United States. The incidence has gone down, but this is suggesting that there are probably other causes. But the fortification and enrichment of our foods with nutrients does have an effect on the adequacy of nutrient intake in the United States. And you see, for those nutrients that are mandated, thiamine, riboflavin, niacin, and iron, there has been a marked reduction in the incidence of intakes below the EAR for thiamine, also for iron, and riboflavin and niacin. Same is true for folate now. Vitamin D, some reduction. Vitamin A, some reduction, but not nearly as much as what is observed with those nutrients that are mandated for fortification. So, what are the limitations and the challenges of food fortification today versus when it was started about 80 years ago? One challenge is that we lack clear physiological indicators of nutrient inadequacy. Today, we tend to focus fortification programs on evidence of insufficient intakes of a nutrient rather than clear health or clinical problems. And this makes it difficult to identify the populations that are clearly at risk. And you will hear more about that this morning. Another challenge is that we have diverse food patterns among our different cultural groups within the United States that makes it very difficult to select a food vehicle. For example, within the US, some populations have rice as their staple grain rather than wheat. Some people avoid milk and dairy products because of intolerance. and some avoid consuming salt or margarine because of concerns about the intake of those particular food. Another challenge that we have is, can food fortification improve nutrient intakes without exceeding the upper limits that have been established by the DRIs for those nutrients? And there are some examples now that suggest that we are reaching that point. And finally, a concern is the physiological availability of fortified nutrients is relatively unknown. By physiological, I mean how well that nutrient is used within the tissues for nutrient function. And I want to give you an example of that from the zinc field. This is a study that was done by Dr. Ken Brown and one of his students, where he compared the changes in plasma zinc following 15 days of zinc supplementation or fortification among Senegalese men. So here are the controls. After 15 days, you wouldn't expect a change in plasma zinc. This is the data from those that were supplemented with 7.5 milligrams of zinc a day as zinc sulfate. And you see there was a marked 5-fold increase, change in plasma zinc. However, when 7.5 milligrams of zinc was given as a forticant to wheat bread, no change in the plasma zinc content. And when they added 15 milligrams to the wheat bread to account for differences in zinc absorption when you consume it with food rather than as a supplement, still no effect on plasma zinc. What does this mean? We really don't know. Does it mean that we use the zinc differently when it's given as a supplement versus when it's given with food? And which situation is the better one for maintaining physiological function? So, in conclusion, we have data from past that shows that food fortification can effectively reduce nutrient deficiencies and improve public health. However, we need to remember that if our focus is on health impacts, it reflects the total amount and quality of nutrients supplied, not just the intake of the fortified food. And I know you're going to hear more about that this morning, but I think we tend to forget that it's the whole diet that influences our nutritional status, not just the intake of the forticant. Challenges for moving forward: what are the indicators of exceeding the nutrient upper limits or creating nutrient imbalances? This is a relatively uncharted area in our nutrition research. How do we target specific populations, such as children or pregnant women, without harming others? Is it appropriate to mandate a forticant for everyone if the target population is pregnant women or a certain specific age group? And what criteria should be used to identify a need for fortification? Diet inadequacy alone, or should there be a health risk along with that? Thank you very much.